Welcome to Stroke Matters, the podcast where leading minds in cerebrovascular medicine unpack the science, the struggles, and the solutions shaping stroke care worldwide. I'm your host. Today we have a special conversation sparked by a landmark paper published in Frontiers in Neurology on February 19, 2026. The paper is titled MTAS-MENA, Adapting the Stroke Access Barrier Index to Enhance Mechanical Thrombectomy Access in the Middle East and North Africa region. I'm joined by three extraordinary guests. The first author of this study, Dr. Ossama Mansour from Alexandria University in Egypt, co-author and regional expert Dr. Ibrahim Alnaami from King Khalid University in Saudi Arabia, and Dr. Santiago Ortega-Gutierrez, president of the Society of Vascular and Interventional Neurology from the University of Iowa. Gentlemen, welcome to the show.
Delighted to join you. As someone who watches the global landscape of interventional neurology closely, this paper raises important questions that go well beyond MENA. They speak to how we assess and dismantle barriers to care everywhere.
Thank you so much. It's wonderful to be here and to discuss this work with colleagues I deeply respect.
Thank you for the invitation. This is a topic that is very close to my heart, and I think today's conversation can really matter for patients across our region.
Dr. Mansour, let's start at the beginning. Mechanical thrombectomy, or MT, has been described as one of the most effective treatments in the history of medicine, a number needed to treat of just 2.6 to prevent disability. Yet less than 1% of eligible patients in low-income MENA countries receive it. How did this gap inspire the study?
That statistic, less than 1%, is the one that kept me up at night. In Alexandria, I see patients every week who had a large vessel occlusion stroke and simply never made it to a thrombectomy suite. Not because the procedure doesn't exist here, but because of a cascade of barriers. They didn't call an ambulance, they arrived too late, imaging wasn't available, there was no trained operator on call. We knew these problems existed, but we had no structured tool to measure them systematically across the region. That was the genesis of SABI, the Stroke Access Barrier Index.
And I'd add that the MENA region is extraordinarily heterogeneous. You have Qatar, a high-income country where over 65% of stroke patients arrive by EMS, sitting in the same regional framework as Yemen, where EMS utilization may be close to zero and conflict has destroyed much of the healthcare infrastructure. We needed a tool that could capture that diversity, not just describe it in general terms.
From the SVIN perspective, the global MTAS, the Mechanical Thrombectomy Access Score, provided a valuable starting point, but our team recognized when working on that framework that it couldn't fully capture region-specific sociocultural nuances. What Dr. Mansour and his colleagues have done is take that foundation and genuinely adapt it rather than just translating it. That's methodologically significant.
Let's talk about how SABI was actually built. Dr. Mansour, you went through a rigorous multi-step development process, literature review, Delphi panels, pilot testing. Walk us through that.
I started with a systematic review of 127 articles on MT access barriers, globally and within MENA specifically. From that, we assembled a panel of 15 stroke specialists, neurologists, interventional neuroradiologists, emergency physicians, health policy experts from Egypt, Saudi Arabia, Turkey, UAE, and Jordan. We conducted a 3-round Delphi process to reach consensus on the domains and attributes. The final tool assesses 12 attributes across 4 domains: physical barriers, diagnostic and information barriers, financial barriers, and sociocultural barriers. Each domain has a maximum of 9 points, giving a total score of 36. Higher scores mean fewer barriers.
And pilot testing revealed some important refinements?
3 key ones. First, we expanded the sociocultural domain to explicitly include trust in healthcare providers, something that reached 85% consensus in our panel and reflects a real phenomenon across the region. Second, we adjusted the EMS utilization thresholds to reflect MENA realities, defining a severe barrier as less than 10% EMS use, rather than global benchmarks that don't fit here. Third, we broadened our definition of telemedicine to include informal physician-to-physician consultations by phone or WhatsApp, which is actually how a great deal of telestroke happens in our region. The final tool showed good internal consistency with a Cronbach's alpha of 0.82 and inter-rater reliability of Cohen's kappa 0.76.
What I think is particularly important is the content validity index of 0.92 for individual items, and the exploratory factor analysis showing that the 4-factor solution explained 72% of total variance. This is not a tool built on intuition, there is solid psychometric grounding behind it.
That rigor matters enormously if you want SABI to be adopted as a policy instrument. A tool without strong psychometric credentials won't gain traction with ministries of health or international development agencies. The team has done the hard work up front.
Let's get into the results. You surveyed 352 directors of stroke and neurointerventional facilities across 22 MENA countries, getting 102 responses from 17 countries. What did you find?
The headline finding is stark. The median SABI score for the MENA region was 18.5, significantly lower than the global benchmark median of 22.0, with a p-value less than 0.001. When you break it down by income level, the disparity becomes even more striking. High-income countries scored 24.0, upper middle income 19.5, lower middle income 14.0, and low-income countries scored just 10.0, a 14-point range on a 36-point scale, simply due to where a patient is born.
The urban-rural divide is equally alarming. Urban facilities scored a median of 20.5, rural facilities just 13.0. That is a 7.5-point gap, and this matters profoundly because 42% of the MENA population lives in rural areas. Transportation infrastructure showed the largest difference between urban and rural settings, with rural scores at 0.5 versus 2.0 in urban areas.
What I find analytically valuable is the domain decomposition. It tells you where to intervene, not just that barriers exist. Physical and sociocultural barriers were the most prominent across all income levels, both scoring 4.0 out of 9.0 for the region overall. The diagnostic information domain at 6.0 was relatively stronger, suggesting that where investment has been made in imaging and stroke triage protocols, it has had some impact.
The hierarchical clustering analysis identified 3 distinct country clusters. Can you walk us through those?
Yes, Cluster 1 we called the high-performing Gulf countries, UAE, Saudi Arabia, Qatar, Kuwait, and Bahrain. Median SABI score 24.0, excellent financial support at 7.5 out of 9, strong diagnostic infrastructure. But here's the paradox, even these wealthy countries scored poorly on EMS utilization, just 1.5 out of 3, and health literacy at 1.5. Money alone doesn't fix the pre-hospital chain or public awareness.
Cluster 2, the middle-income transitioning systems, includes Turkey, Iran, Jordan, Algeria, Tunisia, and Morocco, with a median score of 17.5. These countries demonstrate that strategic investment in diagnostic infrastructure can partially compensate for financial and physical limitations. Turkey, for instance, has made significant investments in ED stroke triage systems, which shows up in their diagnostic domain scores.
And Cluster 3, resource-limited and conflict-affected. Egypt, Pakistan, Iraq, Syria, Sudan, Yemen, median score 12.0, with severe barriers across all domains. In Syria and Yemen, device availability scored just 0.5 out of 3. You simply cannot perform thrombectomy without devices, and those supply chains are devastated by conflict.
One finding that jumped out to me was that EMS utilization scored a median of 1.0, the lowest possible range, across ALL income levels, even wealthy countries. Why is EMS utilization such a universal failure point in MENA?
This is something I've thought about deeply. In Saudi Arabia, we have world-class hospitals, but many patients or their families will drive a loved one to the hospital rather than calling an ambulance. It's a cultural reflex. People don't trust that the ambulance will arrive quickly, or they don't think of stroke as an emergency requiring an ambulance in the first place. Only 30% of respondents in our survey reported EMS use for more than 30% of their stroke patients. That's a systemic failure of public education, not just infrastructure.
The range in the literature is extraordinary. EMS use for stroke in MENA varies from 1.8% in Morocco to 65.1% in Qatar. That 63 percentage point gap tells you it's not a fatalistic regional characteristic, it's solvable. Qatar has invested heavily in public awareness campaigns, and the results show.
From a global perspective, this mirrors what we see in many lower and middle income settings. The good news is that EMS utilization responds relatively quickly to targeted public awareness interventions, particularly when combined with EMS training programs for rapid stroke recognition and triage. The paper recommends hub-and-spoke empty center models paired with these campaigns, a very practical approach.
And health literacy similarly scored 1.0, with 75% of respondents reporting that less than half of their local population could identify stroke symptoms. This seems like a foundational problem.
It is, and it interacts with everything else. If a patient doesn't recognize that sudden facial drooping, arm weakness, and speech difficulty constitutes a medical emergency requiring immediate action, the best ambulance system and the best thrombectomy suite in the world are irrelevant. The study points toward faith-based education programs leveraging religious networks, school-based programs, and gender-sensitive approaches as priority interventions.
The paper highlights gender-specific barriers as a critical theme. What did you find, and why do these matter specifically for stroke?
Findings here are both important and sensitive. Across the surveyed facilities, 68% reported restricted mobility, affecting women's ability to seek care independently. 52% reported that family decision-making requirements, meaning that a male family member's consent or presence was needed before a woman could receive treatment, affected care seeking. 45% reported a preference for female healthcare providers that could delay treatment when female providers are unavailable, and women showed 20 to 30% lower EMS utilization rates compared to men.
Stroke doesn't respect gender norms, but the healthcare system sometimes does. The time window for mechanical thrombectomy is narrow. We often talk about time is brain, losing roughly 1.9 million neurons every minute during a large vessel occlusion. Delays caused by gender-specific barriers can be the difference between walking out of a rehabilitation center and dying or living severely disabled.
These findings are consistent with published literature from the Gulf Cooperation Council countries, which showed similar disparities in MT access and outcomes between men and women. Solving this requires gender-sensitive approaches, deploying more female stroke specialists, integrating family counseling into stroke education programs, and working with community and religious leaders to reframe medical emergencies as situations where immediate individual action is imperative.
And then there's the devastating impact of conflict. Syria, Yemen, Iraq consistently scored at the bottom.
In conflict-affected countries, device availability scored just 0.5 out of 3 compared to 1.5 in stable countries. Healthcare workforce availability similarly dropped to 0.5. When trained neurointerventionists flee a country, when supply chains for stent retrievers and aspiration catheters are disrupted by war, the infrastructure for MT collapses entirely. And the paper honestly acknowledges a limitation here. Because response rates were lowest in conflict-affected regions, 15 to 20%, our SABI median of 18.5 may actually be an overestimate of the region's true access. The real situation may be even more challenging.
Santiago, you are in a rare position, co-author of both MTAS and SABI. In plain terms, what problem did MTAS not solve that made SABI necessary? And what did SABI change?
MTAS was built as a universal first-pass instrument, 12 attributes across 3 domains: physical, diagnostic information, and financial, scoring 0 to 36. It works well as a global benchmark. But when colleagues in MENA used it, a critical blind spot emerged. There was no sociocultural domain. The tool was developed primarily with data from high-income, largely Western settings. It had no vocabulary for the patient who didn't call an ambulance because a family decision-making protocol delayed action, or for the woman whose restricted mobility and preference for a female provider created hours of additional delay. In MENA, those are not edge cases, they are patterns. MTAS could not see them. SABI adds a 4th domain, sociocultural barriers, worth 9 points, equal to physical or financial. A 15-expert MENA Delphi found literacy, beliefs, and trust drive delays, unlike MTAS's 6-expert global panel.
Were there differences beyond the new domain itself? And what can SABI detect that MTAS simply cannot, regardless of how thresholds are adjusted?
2 important ones. First, EMS thresholds. MTAS uses global norms to define severe EMS underutilization. SABI recalibrated for MENA reality. Severe barrier means fewer than 10% of patients arriving by EMS. That distinction matters when the regional range runs from 1.8% in Morocco to 65% in Qatar. Using a single global cutoff collapses a difference that is clinically critical. Second, telemedicine. MTAS requires formal telestroke networks. SABI broadens the definition to include informal physician-to-physician consultations by phone or messaging, which is how the majority of interhospital stroke neurology consultation actually happens across MENA. Measuring the formal definition alone systematically underscores a capacity that genuinely exists. SABI found 68% site-restricted female mobility, 52% family consent delays, and women use EMS 20-30% less. MTAS misses this. In conflict states, device access scores 0.53. MTAS benchmarks, SABI explains gaps and guides action.
3 years ago, I saw a 55-year-old teacher arrive in Alexandria 8 hours after his stroke. His family drove him in a private car. We found a complete middle cerebral artery occlusion. We could not help him. Every line of this paper is written for him and for every patient after him who should not have to arrive too late. Visit MENA-SINO.com, assess your facility and add your data. Science only changes practice when enough people participate.
We are talking about 450 million people, 42% of them in rural areas with limited stroke access. If SABI directs even a fraction of future investment toward the right barriers in the right countries, the reduction in human suffering is beyond calculation. That is the work, Shukran.
I trained in a country where life-saving treatment was not equitably distributed, and I never forgot what that looks like. Thrombectomy works, the evidence is unambiguous. Whether a patient receives it should not depend on their postal code, their income, or their gender. MTAS opened that door globally. SABI has opened it for MENA. Every region deserves a tool calibrated to its reality. Let's keep building them.